Dear ESTS members and the webinar attendees, my name is Lieven de Pieper. I'm your moderator for today, and I first want to start with the ESTS statement on the coronavirus crisis today. The Board of Directors and Program Committee have carefully monitored the global spread of the novel coronavirus, COVID-19. The health and safety of our participants at the ESTS meetings are the utmost priority. Considering the recent rapid and ongoing developments regarding the spread of the COVID-19, the travel bans being imposed and the health and safety of all delegates and attendees, it has been decided to postpone the 28th European Conference on General Thoracic Surgery in The Hague, Netherlands 2020. We are pleased to announce that the new dates for the Congress will be October 4 from Sunday to 6 on Tuesday 2020. We look forward to you joining us in October 2020, and the Congress website will be updated in the coming days to reflect the rescheduled dates. We hope you understand the extraordinary situation and the decision which has been taken. This is today already the 6th webinar of the 2019 and 2020 series, and today will be about the perioperative management being enhanced recovery after lung surgery, after lung resections, and this webinar is sponsored by Medtronic today. I'm very proud to introduce you to Mr. Tim Batchelor as a guest speaker. Mr. Batchelor is consultant thoracic surgeon at the Bristol Royal Infirmary, and he is a local and principal investigator for many clinical studies in thoracic surgery. But he's also the lead for enhanced recovery in thoracic surgery for the International ERAS Society and the first author of the ERAS ESTS guidelines for enhanced recovery after lung surgery. Therefore, I guess he's our ideal guest speaker for today. Mr. Batchelor, the stage is yours.
Thank you. Do you want to ask these questions now, or?
Well, people can see 3 questions asked by Mr. Batchelor, and you can vote. You can vote on these questions in the poll, so in your right sidebar, you see questions posed in people, and in polls you can see the questions. I don't know if you can do something about the sound of the sirens in the background.
Yeah, I can't do anything about it. So people are voting already, and I can see, so for what regional anaesthesia would you use after vasculolectomy? Some people say, so the majority answer is intercostal blocks, a minority is epidural, around 30% saying paravertebral catheters. In terms of fluid production, when would you be happy taking a chest drain out? It looks quite conservative actually, doesn't it? People saying less than 200 mils in 24 hours, half of people saying that, and only 10% of people saying greater than 450 mils in 24 hours. And then in terms of how many of you have an enhanced recovery program, around 40% do have one and around 60% don't have one at the moment. So that's quite interesting. And I hope that during this presentation then, we'll be able to pick up on some of the evidence for enhanced recovery. So I'm just going to start the presentation now. Okay. So, can you see that, Lieven? Is that up filling the whole screen?
No, not yet. So you enabled screen sharing?
Yeah.
In the actions, enable screen sharing. Now it's coming.
Yeah.
And then to the presentation. Perfect.
There we go.
Okay, great.
So, we'd like to thank Medtronic for sponsoring this ERAS session today. So, plenty of you will have had surgery, I'm sure, or know people have had surgery. Around 320 million people a year will have an operation, which is great, and we like to operate on people, but that comes at a cost, and around a quarter of the people will have a complication. And in thoracic surgery, that's even greater. So more like 35 to 40% of patients will have a complication after their lung resection surgery. Now, some of you will have run a marathon as well. This is a picture of Mo Farah. And then when you were preparing for your marathon, I'm sure if you were smoking, you would have stopped smoking. You'd have trained a lot for the run. You'll have got the best kit and the best running shoes. You'll have carbohydrate loaded before the race. And then afterwards, you would have planned your recovery. Now, interestingly enough, having a major operation like a lobectomy is the same stress response on your body as running a marathon. And yet, we don't prepare our patients in the same way that we would prepare ourselves when we want to run a marathon. Now, some of you will recognize this man. This is Henrik Kellett. He's a professor of surgery in Copenhagen in Denmark, and he is really the father of enhanced recovery. In fact, he called it fast-track surgery to start off with, and he was one of the first people to recognize that you had to prepare patients for surgery. On top of that, he looked at the entire patient pathway and tried to find improvements in that pathway to enable his patients to get better sooner and leave hospital quicker. So the Enhanced Recovery Society was born out of his teachings, really. And if any of you want to have a look at this paper in JAMA in 2017, this is a really nice summary of the philosophy of enhanced recovery after surgery. It's written by Olli Lundqvist, who's the president of the ERAS Society. There's this quote in the middle of the paper, which says, "The group was focused on enhancing recovery and reducing complications by modifying the metabolic response to surgical insult, rather than just limiting the length of stay." And that's quite important. People think of this as fast-track surgery and trying to get people home quicker and with a focus on length of stay. But no, the focus is on actually reducing the metabolic response to surgery, that harmful surgical response. And as surgeons, we're guilty of just focusing on what we're doing in the operating room. And ERAS is a completely different approach, a completely different philosophy, where we're actually looking at the entire patient pathway from the moment the patient is referred to you to the time that they go home and beyond. It's about removing dogmatic practice. So what do I mean by that? It's practice which has no evidence base, and you just do it because you think it's the best thing or because it's what you were taught from previous generations. It's looking at the best evidence that we have available and using it. And then it's also incorporating this philosophy of the aggregation of marginal gains. Some of you may be familiar with this, particularly those of you who are interested in elite sports, such as cycling and football. In fact, most sports teams will use this philosophy now, whereby multiple tiny improvements in a pathway can result in massive improvements on the football field or on the cycling track. Importantly, enhanced recovery standardizes care. So each patient should be subject to exactly the same treatments. It shouldn't rely on who is around at the time. And also, importantly, it's delivered by a multidisciplinary team. So that means not just the surgeon, but the anesthesiologist and the nursing staff on the ward and the nursing staff in the operating rooms and then the pre-op department and the physiotherapist and everyone else you can think of who might be involved in the management of a patient. So here's a little bit of science for you, and this is the only bit of science in the whole presentation. But what happens when you have an operation? What is the stress response to surgery? Well, what happens is we get activation of the hypothalamic pituitary adrenal axis, and at the same time, activation of our sympathetic nervous system. So this is what happens in nature. It's our flight or fight response. But after surgery, it can be potentially harmful, because what happens is that we get a rise in catecholamines, in glucocorticoids, and in glucagon. And at the same time, a load of cytokines are produced. Now, this release of hormones and cytokines results in mobilization of our energy reserves, so whole body protein catabolism and insulin resistance, and this leads to hyperglycemia. So these aren't necessarily good things to happen to you, because with catabolism, we have a loss of protein and we have cellular dysfunction. And with insulin resistance, we know that that impairs cellular function during injury to the tissue itself. So are there elements of perioperative care which can mitigate this? Well, yes, there are. If we provide nutritional support, and that can reduce the effect of catabolism, and carbohydrate loading, which we'll talk about, reduces insulin resistance. Regional analgesia is important to reduce the endocrine stress response, and anti-inflammatory drugs like steroids also reduce the endocrine stress response. Early feeding is important so that we have that energy intake, and optimal pain control is important to reduce both the endocrine stress response and to reduce insulin resistance. And at the same time, our anesthesiologists are trying to maintain euvolemia to prevent organ dysfunction and to prevent fluid overload. Okay, so that's the science. That's what we're interested in achieving. But this is a nice graph really looking at the patient and the patient's journey through their operation. So on the y-axis here, we have their level of functioning. This is what they're doing at home. They're walking around, they're going shopping, and then they come in and they have an operation and we harm them. And they become dependent on us because we've harmed them, and then they get better fairly quickly in hospital, and then at some point they're well enough to go home and they get discharged. This dotted line here represents something called the minimal level of functioning. In other words, what a patient has to be able to achieve to be independent of the people around them, to wash, to bathe, to eat and drink. When we do a lung operation, we make this much worse because we're removing vital tissue. So this is more harmful than having more minor operations. And there are certain aspects of the patient which might impact on this. So if you have COPD, or you're unfit, or you're having a pneumonectomy, or you're very thin, then actually the effect of surgery will be much greater than in people who don't have these things. And then similarly, whilst you're in hospital, in the recovery phase, there are a number of factors which are going to impair your ability to recover, such as pain and nausea and poor nutrition, and if you were smoking beforehand, if you're immobile, so you're stuck in your bed, or if you have a large number of tubes remaining in you, such as chest drains, urinary catheters and IVIs. And also, if you are either dehydrated or have too much fluid, then that impairs your ability to recover. And all of these things we can address with enhanced recovery components. Now, there are some patients who just won't recover above this line, or they'll take a long time to recover. So these are the patients who have an inadequate functional recovery. What does this lead to? These are the people who get complications. These are the people who are in hospital for a long time. These are the people when they go home are a burden on their family, require assistance, and may attend the emergency doctor or their family doctor multiple times on discharge. And if they're working, then they may not be able to return to work. So very important to try and address these factors and get people recovered as soon as possible. So with ERAS, we're attempting to get people fit before surgery, to mitigate the stress response to the operation, and then to get them better quicker and get them into a better place once they're at home. These are the guidelines, which some of you will be familiar with. And what we're going to talk about over the next 15 to 20 minutes is really based on these guidelines with a little bit of extra information. So we can't cover all of them because there are 41 recommendations, but we can certainly go over them in the question and answer session afterwards. So what about the preoperative phase? Smoking. You have a patient, they're at home, they're smoking. What do you advise? It used to be that you said carry on smoking. But now we actually want you to stop smoking. And why? Because the longer that you've stopped smoking after surgery, then the less likely you are to have a pulmonary complication. We don't know the optimum time, but it's likely to be more than 4 weeks. So if possible, you should defer surgery for more than 4 weeks so that the patient can quit smoking. And what about fitness? Ideally, you want someone who looks like this, because you know you can do anything you want to a patient that looks like this. But in the real world, we might be faced with someone like this, an obese smoker who doesn't do very much exercise. Now, interestingly enough, the GOLD initiative, some of you may have heard of this. This is the International Initiative to Manage Chronic Obstructive Lung Disease. Its components of treatment are exactly the same as the components of prehabilitation. So they talk about smoking cessation, they talk about pulmonary rehabilitation, and they talk about nutritional supplementation. And that's interesting, isn't it? Because if you think about this, and you have an unfit person in front of you, can you improve their health outcomes by intervening before an operation and improving their physical fitness? So this is what prehabilitation is interested in. This is a nice recent paper looking at patients who have had a Batchelor. And what this group did is they asked a cohort of patients to exercise. They had a 2-week multimodal exercise program, and the control group did no exercise at all. And you can see this was in clinic, and then this is the day before surgery. If you exercised, you became fitter. But then, importantly, a month after surgery, you were still fit. In fact, you were fitter than you were before you started the operation. Whereas those patients who hadn't engaged in exercise were unfit. And because of that, they're more likely to have complications. Why do I say that? Because there's been a Cochrane review looking at the risk of pulmonary complications with prehab and without prehab, and if you have prehabilitation, less likely to post-complication, also you have a reduction in length of stays.
I'm sorry, there seems to be something with your microphone.
Oh, sorry, I think I just covered that. So you have a reduction in length of stay.
Yeah. Okay.
So this is our pre-op department, and within our pre-op department, we put a lot of emphasis on fitness after surgery. So what happens on the day of admission? So we admit people on the day of their surgery, and we carbohydrate load them. Why do we carbohydrate load them? Because it reduces their insulin resistance. We talked about that earlier on. It's good for the patient, and they come to the operating room in a euvolemic state. So we use this preparation. It's a scientific, high-energy, complex carbohydrate preparation. Or you can use Coca-Cola, or you can use any other soft drink that you want to. You want the carbohydrates in the patient beforehand. So the intraoperative phase, there's a lot to say about that in terms of anesthetics and pain relief and surgery. I'm not going to talk about anesthesia, but we will talk about pain relief right now. So having an operation on your chest is extremely painful. A thoracotomy is the most painful incision on the body. The second most painful incision on the body is VATS, which surprises a lot of people. And of course, not only are we making them sore, we're also removing some of their lung. So if we do not provide adequate analgesia, we are exacerbating what is already a compromised respiratory status. The consequences of that are respiratory failure, poor cough, retained secretions, and pneumonia. So how can we manage this? Regional anesthesia. The gold standard has always been thoracic epidural, but I would argue that the gold standard is no longer thoracic epidural. In fact, we have another Cochrane review comparing paravertebral to thoracic epidural. They are equivalent in terms of their pain relief, and paravertebrals have less side effects. So in the ideal world, we should have moved away from epidurals, both for thoracotomy and for VATS. As we saw in the questionnaire, that a lot of you are just putting intercostal blocks in following Batchelor, and that's very valid. Here we're injecting levobupivacaine. There's a lot of interest in liposomal bupivacaine, although there's no evidence as yet that it has any particular benefits. So what about systemic analgesia? We need a standardized multimodal approach to pain relief aimed at reducing opioid use. And this is crucial. Opioids are they're necessary, but they can be bad for you. We know that analgesics have synergistic effects, particularly acetaminophen or paracetamol, and non-steroidal such as ibuprofen, ketorolac, diclofenac, when given in combination. So everyone should have these unless there are contraindications. We'll briefly talk about these other medications now. So ketamine, some of you will know it as Special K, but Special K or ketamine is a useful adjunct, a useful opioid-sparing adjunct to normal analgesia. It reduces opioid use, it improves respiratory function, and it potentiates thoracic epidural anesthesia. So we try and use ketamine whenever possible. Steroids, glucocorticoids, again, important. You can use dexamethasone, methylprednisolone, whatever you need, but they work in a dose-dependent fashion. They're good for analgesia. They are also very good for nausea. This is a nice study from Copenhagen looking at high-dose methylprednisolone after vasculolectomy and showed significant reductions in pain as well as nausea with the use of high-dose steroids and without an increase in infection, which a lot of people are worried about. Gabapentin, you'll see that a lot of people like gabapentin as part of their enhanced recovery programs. And we sometimes use it as well. We have a trial going on at the moment to see if it works. The problems with gabapentin is that it hasn't been shown to work as yet, but there are ongoing studies, and it can be associated with complications such as tiredness, blurry vision, and various other things. And that's in a dose-dependent manner as well. So we'll wait to see whether gabapentin is really as good as some people think it is. So putting all of that together, this is a nice paper from Linda Martin's group in the USA, one of the first publications on ERAS, multimodal approach to pain relief. Blue is VATS. So this is intraoperative opioid use before ERAS, and this is post-operative opioid use before and after ERAS. And you can see that the opioid use went right down with a multimodal analgesic approach, and that was true for VATS, and it was true for thoracotomy as well. So reduced opioid usage, and that also resulted in a reduced length of stay. So what about surgical technique? What are we doing? Thoracotomies are sore, there's all sorts of things going on, fractured ribs, nerve damage, muscle damage, but the important thing seems to be intercostal nerve damage. So is there anything that we can do as surgeons to reduce that? Well, yes, there is. We can use muscle sparing techniques, sparing the serratus anterior muscle or doing anterolateral thoracotomies. There's some evidence that that is of benefit. And there's also publications about sparing the intercostal bundle before you put the retractor in, and that seems to influence both acute and long-term pain. When you're reclosing the thoracotomy and using sutures that go around the ribs and spare the intercostal bundles, there seems to be some evidence for that as well. But of course, as thoracic surgeons, a lot of us are interested in VATS, and minimally invasive surgery is a cornerstone of enhanced recovery programs and other specialties. There's advantages to VATS being reported in the literature: less pain, better shoulder function, earlier mobilization, a better quality of life, possibly better 5-year survival. So you've all seen this in the literature, and this is what the VATS enthusiasts go on about. But there are problems with the VATS lobectomy studies. We need to take these findings with a pinch of salt. There's very definite selection bias. There's reporting biases as well. Not all studies have been reported. The studies that have been reported are usually by top performing surgeons in university hospitals. And the voluntary national databases often have poor quality data. So you'll have seen propensity matching. It doesn't matter if the propensity matching will not work if you've only got poor data to start off with. And also, you'll see that the care of VATS patients is often different. You'll often see that a VATS patient only has one chest drain and they don't have an epidural, and they're rounded on twice a day and they're encouraged to mobilize. So there's a lot of confounders when we're looking at the evidence for VATS. Now there are 2 trials, in fact. This is the famous trial from the Lancet Oncology, from Peter Licht's group, which randomized patients into having either a lobectomy via anterolateral thoracotomy or a lobectomy via VATS. And what did they demonstrate? Well, that there was less pain and better quality of life up to a year down the line, which sounds impressive, and it is, but actually the differences between the 2 groups were really quite small and not as great as you might think they were. Another study, which hasn't been published yet, but which has finished recruiting, is Violet in the UK. Again, we randomized over 500 patients to either lobectomy via thoracotomy or lobectomy via VATS. We only have the initial in-hospital results, which were presented at World Lung. There's actually very little difference in pain. Complications, though, significantly less than the VATS group. Lower length of stay, and importantly, no difference in nodal upstaging, so they appear to be equivalent oncological operations. So from that, we should say that VATS is preferred to open surgery. Uniportal surgery, there's a lot of talk amongst some very enthusiastic surgeons about uniportal, about how it's best. And it may be, but we have no evidence. We've got evidence to suggest that it's equivalent, but we don't have any evidence to say that it's better than a 2-port or a 3-port or even a 4-port technique. So in other words, we should carry on doing minimally invasive surgery. Should we be doing it with the robot? Possibly, but again, we have no evidence to show that the robot is any better than VATS. Okay, so we've done the operation. The patient is back on the ward and getting better. What do we want to do? Something which bothers surgeons more than anything else is chest drain management. And why? Because you drain pain. It hurts. We want to get the drain out as quickly as possible. There are quite a few questions to answer with chest tubes. How many do you put in? 1 or 2? Because the tradition is to put 2 in. The reality is you only need to put 1 in. It's less associated with less pain, less fluid production, and there's no increased risk of adverse events. So you only need 1 drain. And what about pleural fluid drainage? This was a question we asked at the beginning of the session, and most people, it seems, want to keep the drains in until there's less than 200 mils per 24 hours. Sofolio's group showed that it was safe to remove the drain even if there's 450 mils a day of fluid output, and the Copenhagen group has said 500 mils, and other people have gone even further and said it doesn't matter. Mm-hmm. So I don't think we need to be as conservative as we have been in the past. What about digital drainage systems? Should we be using those as opposed to the old-fashioned underwater drain? Well, possibly. This is a complex slide, but it is essentially a systemic review and a meta-analysis of traditional chest drain systems compared to digital drains. Some studies showed no difference between digital drains and normal drains, and some studies did show a difference. Overall, there appears to be a slight difference in outcomes in terms of length of stay and what have you in terms of digital drainage, but it wasn't so great in these studies. However, this paper from Salamanca in Spain, I think, is what's really important, and they've shown that if you have a digital drain, it reduces the variability between observers. So the decisions to take a chest drain out can be made much more easily if you've got a digital drain in. So that's probably its greatest benefit. And then suction versus no suction. The tradition was to apply suction all the time. Why? Because there is thoughts that it might improve pleural apposition and treat surgical emphysema, but the reality is that it actually may promote an air leak, and you get more fluid production because of the Starling forces, and it makes people immobile. Ultimately, there's no real evidence that suction is better than no suction, so therefore you should not routinely apply suction to a drain. This study, fairly recent, again from the Copenhagen group, using ultra-low suction via a digital drain in vaccillobectomy patients. They had a group of patients on -10 centimetres of water, a group of patients on -2 centimetres of water, that's -0.2 kilopascals, and what they showed was a reduction in air leak duration and a reduction in chest drainage duration as well, and a reduction in length of stay. So we've really covered everything with this trial. So when can you pull your drain? Essentially, as long as there's no chyle, no blood, no air, and no pus coming out of the drain, just pull the drain. Finally then, we'll talk about mobilisation. Is this the ideal patient? The nursing staff think so, well hydrated, nice and comfortable, not doing, causing any problems on the ward, but maybe not the best way to get better. One of the problems with modern wards is that everything is given to the patient at the bedside. The food, your TV, your urinary catheter, you don't have to get up to go to the toilet, and this is detrimental to the patient. We did a study looking at protocol compliance with ERAS, and we showed that if the more compliant you were, then the less chance you had of having a complication and the less chance you had of staying in hospital. But one of the more important things we showed is that early mobilisation reduces morbidity and promotes early discharge. This is a nice paper from Virginia. You don't have to look at this protocol, but essentially they just got people walking an hour after their lobectomy, and they walked them back to the ward, and then on the first post-operative day, they had to walk 10 times, and so on and so forth. And what they found was that people were going home very, very quickly because there was such a huge focus on early mobilisation. And interestingly, this is a paper that's come from Boston. You'll recognise this author here, Atul Gawande, a famous author. They looked at people's smartphones before and after surgery, and they showed that the more active you were, based on the steps taken on your iPhone, then the less likely you were to have had a post-operative event. So, do the guidelines work? Well, we're not quite sure because they haven't been tested, or rather they hadn't been tested until this publication. So this is still in press and it's waiting to be published. It comes from San Francisco, from Johannes Kratz and team, and they've looked at the guidelines and incorporated them into their everyday care, 300 patients, and they've shown increased minimally invasive surgery, reduced ICU admissions, reduced use of epidurals, quick removal of urinary catheters and chest tubes, quicker mobilisation, and quicker early discharge. The reality of what that has, what the outcomes of that are reduced length of stay, lower morbidity, lower opioid consumption, and lower costs, and importantly, no change in readmission rates. So this is really the first test of the guidelines and appears to show what we thought they were going to show, in that you get better outcomes for the patients. And then finally, this is the group from MD Anderson, showing that those patients in an enhanced recovery program are more likely to engage with adjuvant chemotherapy after their surgery, and what's called a return to intended oncological treatment. So it may well be that enrolling a patient in an enhanced recovery program improves their lung cancer survival, as well as improving their inpatient outcomes. So, of all the patients that are coming into hospital for surgery, around a quarter will have a complication, maybe more for thoracic surgery, but ERAS has the potential to reduce that by half. By half, that's amazing. If that was a pill, a tablet, a medication, just think that would be a multi-billion-pound industry, multi-billion-dollar industry. But this is ERAS. It's not too complicated and it's free. Okay, so thank you very much. That's the end of the presentation. So we'll go back onto the main screen for questions.
Thank you for this very comprehensive overview. I would like to ask to the audience to ask some questions to Mr. Batchelor. Maybe in the meanwhile, so if you look at your right sidebar, the left one is questions. There you can put in some questions, and then we can go through these questions. Maybe in the meanwhile, you can comment a little bit on the polls. I don't know if everyone has voted yet, but I think we already had some answers from the talk. So about the fluid production and the regional anesthesia.
Yeah.
Do you have any comments?
Shall I start that? So I'll actually start from the bottom again. Who has an enhanced recovery program? Around half of people do, and half of people don't. So that's interesting in itself. We can talk about the barriers to starting a program, but the guidelines are now there. They seem to work, but you need to get together with your anesthesiologists and your ward nurses, your operating room nurses and your pre-op team to try and formulate an enhanced recovery program looking at the entire patient pathway from the beginning to the end. You don't have to do everything all at the same time. You can introduce little bits, one thing at a time. But if people have questions about that, then please write in.
Question if we can see how many people responded. I'm just having a look. I think we are having over 130 people watching this webinar, and let's say that about half of them responded to the questions.
Okay. So in terms of chest drain management then and pleural fluid production, this is interesting. So we talked about is it necessary to have a limit on the amount of fluid that you would accept before you're happy to remove the chest drain? And in the poll here, we have 39% of people saying they'd want to keep the chest drain in until there was less than 200 mils per 24 hours. So 38% of people say 200 to 300 mils, 16% are saying 300 to 450 mils, and only 6% are saying greater than 450 mils. So the reality is that you can probably take the drains out at around 450 mils or even higher. So chest drains themselves stimulate pleural fluid production. We know that suction stimulates pleural fluid production. We get disruption of the Starling forces, so we get greater production and less absorption of pleural fluid. Your pleura is incredibly efficient at absorbing pleural fluid. It can cope with several liters a day of pleural fluid production. So the concept that you have to leave the chest drain in to remove all the fluid is not necessarily true. So we have seen studies in Europe and in North America which have suggested we can take the chest drains out even at 450 mils per 24 hours of fluid production. And why is that important? It's important because chest drains are painful. We know from Brunelli's work that if you remove a chest drain, then a patient's FEV1 and FBC improve immediately. And you also need less analgesia and less opioid analgesia. So
is it important to have a smaller drain then? That is.
Yeah. Okay. Yeah. So that's important. So that's an interesting question, and we don't have a true answer to that because the studies are lacking. We know from work on pleural effusion and pneumothorax that it doesn't really matter what size the chest drain is. When I first started training, then we were using 32 French chest drains, and then we went down to 28 French, and now we're down to 24 French, and we know that some people are using 20 French and smaller. I there's no real evidence that reducing the size of the chest drain is harmful for the patient. In other words, they're more likely to have a pneumothorax or pleural effusion or hemothorax, and it may result in less pain. So if possible, we would advocate using a smaller chest drain, but I'm afraid there isn't a robust evidence base around that at the moment. That's just taken from work we know about from other branches of medicine.
Okay.
Should we talk about regional anaesthesia, as that was one of the polls as well? So it says here, we asked what regional anaesthesia would you use after vaccillobectomy? And I guess we could ask the same question after thoracotomy as well. So just over half of people are using intercostal blocks only. So that's interesting. We use intercostal blocks and paravertebral catheters. But there's good evidence about intercostal blocks using bupivacaine. Of course, the effects of that will only last for 12 to 16 hours or so. In North America, if anyone is looking in from North America, then there's a preparation available called Exparel or liposomal bupivacaine, and that is a bupivacaine preparation that can last for up to 4 days. So there's a randomized controlled trial, very small, which has just been accepted by JTCVS, which has shown no real difference in analgesia between that and conventional bupivacaine, and whereas there had been non-controlled studies which have shown that liposomal bupivacaine, just as a single block, is as good as epidural analgesia. So I think we've got a little bit to go, really, before we can recommend liposomal bupivacaine, but intercostal blocks, really important. Interestingly, very few people are using epidurals. That's not true in North America. A lot of North Americans are still using epidurals. Part of that is due to the way that healthcare is paid for over there, but we should really be moving away from epidurals, even for the thoracotomy patients, because there are many harmful effects in terms of hypotension and requiring fluids or vasopressors, and also the immobility that causes. Okay.
Okay. Then I think we can go to the questions. Maybe we take the first question, which is down on the tab. Question: is the presence of a chest tube considered a contraindication for fibromatic chest physiotherapy? No.
As far as we're aware, there's no contraindications to chest physiotherapy. Arguably, early mobilization is the most important thing rather than specific chest physiotherapy. Clearly, the chest physiotherapist can help with that, but no, a chest drain is not a contraindication, I don't think. Okay.
Would you prescribe NSAID medication, non-steroidal anti-inflammatory drugs on the post-operative day 1, given their antiplatelet effects?
So this is a good question, and the answer to that is a very definite yes, so long as there are no contraindications. So we would generally give them to people who are less than 70 years old, who have had no side effects to non-steroidals in the past, who don't have a history of GI bleeding, and who don't have renal dysfunction. So patients should get non-steroidals in the operating room as an intravenous preparation or an anti-inflammatory, and then we start non-steroidal drugs immediately. We do that in combination with paracetamol or acetaminophen. They work very well in combination. They have a synergistic effect. People worry about bleeding and healing. There's no real evidence that starting non-steroidals early have an effect on that. The same is true after pneumothorax surgery and pleurodesis. A lot of people are very wary or scared of starting non-steroidals after pleurectomy or pleurodesis. Again, there's no evidence that you affect the efficacy of the pleurectomy or the pleurodesis. So, you should give non-steroidals along with all the other non-opioid analgesics early, as soon as we can.
Okay. About the intercostal blocks and uniportal VATS, how many intercostal spaces do you infiltrate?
We infiltrate widely for both uniportal and multiportal. So generally, we would go from the 2nd to the 10th intercostal space. There is an argument for being more directed and just involved in the intercostal spaces that you've used. I don't think we can say one way or another, but we go widely from the 2nd to about the 9th or 10th space there. You
don't see any problems with the fusion of the bupivacaine in the circulation, because the intercostal veins can... in people, then you can have problems with bupivacaine toxicity. We used to see that when we were using different preparations for paravertebral and intercostal infusions. So we were using very high volumes, up to 20 mils an hour of bupivacaine, and once or twice we saw bupivacaine toxicity. We haven't seen it at all over the last few years. So our infusion rate is 6 mils an hour, or I think of a 0.375% preparation. So it's quite rare, but if you see it, then you should stop the infusion straight away. There's some evidence in other specialties for intravenous bupivacaine as well, but there's nothing in thoracic surgery. Okay. Then an interesting one. How much should a surgeon insist on his patient losing weight before surgery?
Okay, so that is an interesting question. And the answer to that is probably you don't need to get them to lose weight. So there is something called the obesity paradox, whereby patients who are fat actually do better after surgery than patients who are thin. They have more reserve in terms of muscle mass and fat, and reserves that they can draw on when they are in that catabolic phase, which we described at the beginning of the presentation. I think we should not concentrate on the fat people, and the fat people make it more difficult for us to operate, but it's the very thin people who we need to concentrate on. So if your BMI is less than 20, or certainly less than 18.5, then you're at high risk of a complication. In fact, your risk is about 3 times greater than if your BMI is between 20 and 25. And so these are patients who should be identified in the preoperative clinic. They should be nutritionally assessed, and they should be given nutritional supplementation, both in the weeks leading up to their surgery and during their in-hospital stay. And indeed, in our hospital, we give everyone nutritional supplementation, whether they're fat or thin, during their time in hospital. That's a very good question, though.
Okay.
Yeah.
Are you working with a database system from ERAS, and how much time per patient to fill this in?
We do have our own in-house database system at the moment. It's generic and it's for all specialties, so not specific to thoracic surgery, but it covers things like regional anesthesia and early mobilization and carbohydrate loading. And we can see, and in fact we published, that the more compliant you are, then the more likely you are to have better outcomes. Mm-hmm. It's very difficult to get 100% compliance. We have around 70 to 80% compliance, which is very good. We are working with the ERAS Society on producing a commercially available ERAS database, and that will cover all the measures that are described in the ERAS Society and ESTS guidelines. We know from work from colorectal surgery and orthopedics, again, that the more compliant you are, then the less likely you are to have complications and a long length of stay.
Okay. How important is the ERAS nurse for educating the patient preoperatively?
vitally important. Your ERAS nurse is one of the most important members of the team to set the expectations of the patient. We know that patient education is important for a whole host of factors, but patient education reduces post-operative nausea. Patient education reduces post-operative pain. The patients are more likely to mobilize early. The patients are more likely to have an early discharge. There's also evidence now emerging from Canada that you can reduce readmission rates and you can reduce attendances at the emergency department with good patient education.
Okay. What's your strategy on the preoperative non-smoking enforcement?
Yeah, again, this is a good question, and people have different philosophies on this. We talked about how important it is to not smoke before surgery, and we think that the minimum time between stopping smoking and having surgery is around 4 weeks. However, you have to accept that some patients can't wait because they have large central tumours or they have nodal disease, and we know that each week matters. You also have to accept that smoking is an addiction to nicotine, and some people cannot come off that addiction in the few weeks that they have before surgery, particularly when they've just been given a cancer diagnosis. So you have to take a pragmatic approach. If you have someone with an early stage lung cancer who can stop smoking, then you should defer surgery for 4 weeks before they have their operation. However, if someone is not going to stop smoking or they have a large central tumour, then I'm afraid that you have to operate and accept that there are increased risks. Salamanca has produced various publications and they have shown that if you are rigorous in your post-operative regime, then you can reduce post-operative pulmonary complications. So by that, we're talking about early mobilization, aggressive chest physiotherapy. We give carbocystines, they're a mucolytic. We give nebulizers, try and get the drain out as quickly as possible so that they have as little pain as possible. And in some patients, there's evidence for placement of a prophylactic mini tracheostomy as well. That seems to improve patient outcomes. So just because the patient's smoking doesn't mean they shouldn't have an operation.
Okay. Then some question on carbohydrate loading. What's the quantity, and can diabetics also do the same?
Yeah, so we give carbohydrate loading in the form of a complex carbohydrate drink 2 hours before induction of anesthesia. Most people, so me, for example, could have a drink, some water, 45 minutes before anesthesia, and there is no risk of aspiration. So that is what people are worried about. But 2 hours seems to be a reasonable time. So people should not be starved for surgery. We give 400 mils of a complex carbohydrate drink. Other people give a can of Coca-Cola or Gatorade or whatever. So that's what you should do. And if the operation's delayed, then you should be in contact with the patient so that they can carry on drinking until 2 hours before the operation. Can diabetics do it safely? That's a really good question. The true answer is we don't know. If you're concerned, just give them water. They can have water before their 2 hours before surgery. We do give diabetics carbohydrate loading there.
Okay. Then 2 questions about the local regional anesthesia again. First one, do you prefer paravertebral block or epidural? And then the next one, what's the composition of the paravertebral block?
So I hope that's come out in the presentation. We do not like epidural. Epidural is associated with hypotension and the need for more fluid. Fluid is bad. Fluid causes nausea. You're less likely to mobilize, and it increases your length of stay. So we have been using paravertebrals for 12 or 13 years now, and we're very happy with them. Even for large thoracotomies, you can even use them for decortications and other operations, rib fixations, chest wall resections. There are times when you are still going to need an epidural, the big chest wall surgeries, but most of the time a paravertebral is our go-to regional anaesthetic block.
So no indications at all?
Beg your pardon?
So no indications at all for epidural?
Epidural for maybe bilateral surgery or the really big chest wall surgery, but otherwise it's very rare for us to use an epidural.
Mm-hmm.
The next question is about the composition of the paravertebral block. So our intercostal blocks are 0.25% levobupivacaine. We use 20 mils generally over multiple levels, and then we place the paravertebral catheter. That is loaded with another 20 mils of 0.25% levobupivacaine, so the patient will have 40 mils altogether intraoperatively, and then we start the infusion immediately, and that's 6 mils an hour of 0.375%. 5 mils an hour of 0.375%, and that's given via a ball, an elastomeric ball, which is very portable. We would like to move away from that and use liposomal bupivacaine if that becomes available in Europe and if the evidence suggests that that's a good thing to do.
Okay. Question about quality of life. Have you learned quality of life from patients through ERAS protocol versus classical protocol? What are their comments towards teams applying ERAS?
That's, again, a really good question, and I think a really important question, isn't it? Because that's a patient's outcome. That's something that the patients are interested in. Because ultimately, the patients don't care so much if they're in hospital for a day longer, and they don't really care so much whether they have an open operation or a VATS operation. They care to a certain to a certain degree. But the things that we found that patients are most interested in are, can you get the cancer out? And am I going to be okay afterwards? So in other words, what their post-operative quality of life is. We don't have any data really from ERAS. We can make some suppositions that their quality of life will be better because their stress response on the body is less and they seem to improve more quickly. And I think if we're going to do studies on ERAS, then quality of life is one of the things we should be looking at. What we do know from the 2 VATS lobectomy studies, or certainly from the Ben Dixon study, quality of life was improved after VATS lobectomy, and VATS is a component of ERAS. The Violet study, that is our primary outcome measure, is quality of life at 5 weeks, and then again at 1 year. And so we'll wait and see what the quality of life outcomes are. We anticipate they'll be better, but we don't have any hard evidence at the moment.
Okay. We said 1 chest tube instead of 2, and then the question is, what type of tube do you prefer after an upper or lower lobectomy, straight or angled?
We use a straight tube. We use a 24 at the moment. I think you just use what you're comfortable with.
And all lobectomies, upper and lower?
It doesn't make a difference. We put 1 tube going to the apex. We often cut a separate hole a little bit lower just to cover the basal space. I'm not sure that really matters because the pleural fluid circulation is such that the fluid should come out of a chest drain, whether it's placed at the apex or the base. So no, we tend to put them in the same place. Okay.
Then about the rehabilitation, how long would it be recommended? 4 weeks as the smoking cessation, or do you think that educating patients to promote them doing exercises at home could be sufficient before surgery?
Okay, so this is prehabilitation rather, so exercise before rather than a rehabilitation after surgery. So that's an important distinction. Again, really good question. And the reason being is that although people have published on prehabilitation, there have been a lot of different regimes. People are looking at cardiovascular fitness, and they're looking at core strength, and they're looking at specific respiratory muscle exercises, in particular inspiratory respiratory muscle exercises. The bottom line is no one has really described what a prehabilitation program for lung cancer surgery patients should look like, both in terms of the exercises and the duration. Now, that study I showed you was a 2-week exercise program. We've had other papers from Italy describing intensive 3-week programs with high intensity interval training, and other programs with 4 weeks. At the same time, the Birmingham group here in the UK just said it doesn't matter. Sometimes you only have a week to operate, just get them exercising in that week, and that's better than nothing. But the optimum time, we don't know, but possibly 3 or 4 weeks. Should we just educate the patients to do it at home? Again, there's research being done into that at the moment. So rather than directing the patient and having one-to-one classes in the gym, actually having app-based programs. So there's quite a lot of interest. I know there's a group in Spain looking at this. We've got a group in the UK and several groups in North America looking at app-based training of programs at home. Yeah, good question, that. Yeah.
So that's for prehabilitation, and the other one is, you recommend a specific rehabilitation program?
No, because there isn't one at the moment. All we have is a study from colorectal surgery from Canada, which compared prehabilitation to rehabilitation, and they showed that patients who had prehabilitation, so in other words, training before their colorectal surgery, did better than patients who had the rehabilitation. So it seems that exercise before surgery is more important than exercise after surgery. However, we encourage all our patients to exercise as much as possible, both in hospital and out of hospital. There isn't a formally described rehabilitation program, although I know other centres do have one. And again, this is another area of perioperative care which needs more research.
Then what is the most challenging part of the ERAS protocol to keep your patients being compliant?
That's good. So clearly there are aspects of ERAS which are dependent on us as surgeons, the sort of surgery that we do and what have you, and our chest drain management. And then there are elements which are dependent on the anesthesiologist. And then there are elements which are dependent on the patient. So possibly the patient-dependent elements are the most challenging, and in particular, early mobilization. So that's not just down to the patient, because there are times when the patient just doesn't want to mobilize, but also it's a philosophy on the ward as well. If your nursing staff are used to the patients being in bed for 2 days, or you routinely nurse your patients on a high dependency unit or intensive care unit, then it can be very difficult to introduce a new philosophy of early mobilization. So probably early mobilization is the hardest thing. Also having new members of staff who are unfamiliar with protocols and start introducing more old-fashioned elements into your perioperative care program.
Okay. Yeah. And a very nice one to finish, I think. Any way to help in convincing all the surgeons to try and adapt ERAS, and which step is the easiest to start with?
Again, yeah, this is a great question. And it's not just old surgeons, it's young surgeons as well who think they know best. And that's the problem with surgeons, that we tend to be egomaniacs. We tend to think we think we know what's best. But my advice is that this is something that you can't do by yourself. You have to do as a group of surgeons. You will have some surgeons and anesthesiologists who aren't as enthusiastic. But this is about changing the culture of the whole team. What you will find is that once you introduce an enhanced recovery program, the nursing staff on the ward will subject all the patients that come through to those same protocols. And so the old surgeon who doesn't want to engage will find that his patients are on an enhanced recovery program, whether they like it or not. Another important thing is data. So you have to collect data. And when you're collecting data, you can show that the outcomes are better. You can have a look when outcomes are getting worse, and I try and identify reasons why that is so, and introduce changes to get things back on track. And if you can show with data that outcomes are better, then you can't argue with that. No one can argue with the data. If patients are getting better on an enhanced recovery program, then you have to do it. It's what's best for the patient. So, yeah, there are lots of challenges. What are the easiest things to do? Well, you pick out the low-hanging fruit. So the things which are easy to do and which don't cost any money. So look at your chest drain management. That's an easy thing to do. Look at getting patients out of bed earlier. That's an easy thing to do. Look at your analgesia regime and take out opioids and start introducing other adjuncts. That's easy. Stop using epidurals. That's an easy thing to do. Carbohydrate loading is cheap and easy, and patient education is fairly cheap as well. So you don't have to go, start doing minimally invasive surgery or doing other fancy anesthetic techniques. You do pick out the easy things first and then work on that.
Okay. We're running out of time, but maybe the very last question then about the X-ray protocol. How often do you control X-ray after lung surgery?
Yeah, good question. We haven't talked about that. I guess it's not really part of enhanced recovery. It's more about making good use of resources. What I always say to the juniors is if you're doing investigation, then the investigation, you have to act on that. So there's no point in doing an X-ray if it's not going to make a difference to patient outcomes. We do a control X-ray in the recovery area, and then we do no other X-rays until the chest tube is removed, unless there is a clinical indication, particularly if the patient is deteriorating. You talk to other centres, so if you were to talk to Henrik Hansen or René Peterson in Copenhagen, then they've chest X-rays altogether. And they would only X-ray someone if there was a clinical indication. So in other words, if the patient was deteriorating. So I think you have to do with what you're comfortable with. I think to start off with, you can go down to the immediate post-op and then one after chest tube removal. And you could go lower than that if you want to. But there's a balance to be had between cutting corners and enhanced recovery. So enhanced recovery is not about cutting corners. It's about doing the right thing for the patient. For sure.
Thank you. Today was, again, a great ESTS webinar. We had over 130 attendees, which is one of the records, I think, and many interactions. On behalf of the ESTS Learning Affairs Committee, I would like to thank you, Mr. Batchelor, for the webinar today, and you, the audience, for your interest and interaction. I hope that all of you can stay safe and be available for your patients during the Corona crisis. I really hope to see you back on the 20th of April with Mustafa Yüksel on the personalized management strategies for chest wall deformity. Thanks again. Take care. Good luck in fighting the virus, and see you next time.
Bye-bye. Yes.